Welcome, dear friends and colleagues, to our session of today's Critical Care Sunday webinars. And the topic is a very important one, post-cardiac arrest syndrome. And it is an evolving field, especially the prognostication, because the prognostication is very important and a lot of work has been done recently on trying to improve the prognostication. And of course, the management as such. So the speaker for today is Dr. Bikash. Sir is additional professor, critical care anesthesia at the prestigious All India Institute of Medical Sciences. So over to you, sir, for the webinar.
Good afternoon, good evening, Dr. Mansal. Should I share my screen?
Yes, please share.
Okay. Again, good evening, everyone. So, suppose you are cruising smoothly in a highway in your life with a car. Suddenly, the car stops. So, what do you do next? You try to repair it or try to pull it out and take that into a garage, where the aim is to find out what is the cause and repair the damage. So, the similar things happen when there is a cardiac arrest. When the heart stops, so you do a resuscitation attempt with the standard BLS or SLS protocol, and there is a return of spontaneous circulation. After that, you shift the patient to ICU or SDU, where you provide some post cardiac arrest care. So today we'll be discussing regarding this important topic of post cardiac arrest care. Myself is Dr. Bikash Rai. I'm the additional professor in the Department of Anesthesiology, Pain Medicine, and Critical Care Aiims. The topic I will cover under the background of what is a post cardiac arrest syndrome, what are the epidemiology and pathophysiology, what is the initial and followed by ICU management with particular importance on therapeutic temperature management, prognostications, and rehabilitation. Coming to the background, why post-cardiac, post-resuscitation care is important? Because as we discussed, to find out the cause and to treat the damage or prevent further damage. It was first in way back in 1970 when Dr. Vladimir first gave the term to this syndrome. At that time, it was named as post-resuscitation disease. Although the name is a bit confusing because resuscitation is a continuing process. When you say post-resuscitation, it means that the resuscitation is over, where it is a continuing process. But later, in 2008, Nonan described this as the term post-cardiac arrest syndrome. So the post-cardiac arrest syndrome basically consists of four components. One is the systemic ischemia or reperfusion response. One is post-cardiac arrest myocardial dysfunction, post-cardiac arrest brain injury, and the precipitating or recurring pathology which lead to the basic cardiac arrest. The important thing is that individual component of all the syndrome has a potential treatable link. So that is why it is later recognized that it is one of the best thing to have a post cardiac arrest link in the change of survival in the standard CPR guidelines, which has been now incorporated since last 1 decade. Coming to the phases of cardiac arrest syndrome, it is basically 5 phases are there. It's the immediate phase, which is post just after the return of spontaneous circulation till 20 minutes. Then from the 20 minutes to 6 or 12 hours, which is the early phase, followed by the intermediate phase, which is from 12 hours to 70 hours, 72 hours, and the recovery, which in weeks, and followed by the rehabilitation, which takes months to years. The main important thing is that the goal of treatment or the care in different phases varies. Prevention or of the recurrence is a continuous process and that should be continued. In the initial, immediate, early, and intermediate phases, is the main aim is to find out what are the cause and support the ongoing injury or organ support. After that, after 72 hours or 3 days, you can go for prognostication and later for rehabilitation. Coming to the pathophysiology, the cardiac arrest basically lead to hypoperfusion and ischemia, which causes disruption of hemostasis, free radical formation, and activation of proteases. If you find out that when the circulation stops, in 20 seconds there is a depletion of the cellular oxygen store because no flow is there. That lead to interruption of cellular functions, and later in next 4 to 6 minutes there is complete loss of energetic or ATP stores, which lead to membrane disruption, influx of calcium, lactic acidosis, free fatty acids, and oxidative stress. And when there is a return of spontaneous circulation, there is reperfusion. That causes a reoxygenation induced reaction, that is free radical generation and excitatory toxicity. Lipid production, primary necrosis, and apoptosis are the mechanism. Similarly, endotoxin release and inflammatory response is followed to these injuries. So with this pathophysiology, uh, now we'll come to the management of the post cardiac arrest syndrome. So the goal of management in post cardiac syndrome is determining and treating the cause of the cardiac arrest that leads to the primary cardiac arrest, minimizing brain injury, managing cardiovascular dysfunction, managing problems that may arise from global ischemia and reperfusion injuries. So it is first initial stabilization followed by proper management. So initial stabilization is basically first thing when the patient comes to the ER or in the or to your ICU, you have to find out whether there is a vascular abscess is there or not. It may be intravascular, or in an emergency scenario, it may be intraosseous. At this stage, a arterial line or central line is not mandatory. However, ultimately, the patient will require a central line and arterial line. Most patients after return of spontaneous circulation are preload responsive, and they tolerate moderate volume of resuscitation. Normally from 1 to 2 liter of fluid is normally given. However, if the patient has a history of congestive heart failure, or the clinical features of the physical examination suggestive of fluid overload pulmonary edema, a restrictive strategy may be followed. Initial vasopressors normally are started along with fluid resuscitation, not in a sequential way, because of everything goes simultaneously. There is no preference of over which vasopressors or which inotropes to use. Normally, we start with the vasopressor that is non-epinephrine. Not maintaining bag. If you are not able to maintain the ventilation with a bag mask or a supraglottic device, intubation followed by mechanical ventilation is warranted. However, for intubating, mostly a rapid sequence induction is done. And in a hypotensive patient with induction agent, there is a chance that there may be further hypotension. Most of the time, etomidate is used, and there has been report where am I
Just speak a little slowly. You're audible. Speak slowly. Nowadays is okay. थोड़ा सा slow.
Okay. So, though, uh, so coming to the vasopressors are normally started in parallel with the fluid resuscitation. Mostly norepinephrine is the choice. And if you are not able to maintain the bag and mask ventilation, or if you are not able to put a supraglottic device, intubation is warranted. For intubation, mostly a rapid sequence induction is done. However, in a previously hypotensive patient with the induction agent, there is a chance of further hypotension. Mostly, etomidate is used, and there has been report of using etomidate in a lower dose than the standard dose that is used for induction. There is a and the recurrent arrhythmias are managed as per the ACLS protocols. Identifying and treating the reversible cause of cardiac arrest as the prime importance. In the post cardiac arrest care, there is immediate treatment followed by the diagnosis, that is whether it's a cardiac event or a non-cardiac cause. Then the aim is to optimize the recovery. So in the immediate treatment, you always take care of the ABC, that is airway, breathing, and circulation. You always maintain a saturation which is target around 94 to 98%. You maintain advanced airways, and in circulation, you obtain a 12-lead ECG. Aim for a systolic blood pressure more than 100 millimeter of mercury. Give fluids and monitor blood pressures. Consider vasopressor or inotrope to maintain the blood pressure. After this initial treatment, you find out whether it's a cardiac cause or not. So if it is a likely cardiac cause, you obtain a 12-lead ECG and find out whether there is ST elevation or not. The ST analysis is done. If there is a ST elevation, you definitely go for a, there is strong evidence to go for a coronary angiography with or without any intervention. If there is no ST elevation, then also it does not rule out that there is no clot. So there are scenarios, maybe there are certain group of patients which will benefit from this angiography. Then you consider the angiography plus minus PCI in this case also. And if there is no cause of cardiac arrest is identified with the coronary angiography, then the patient is shifted to the ICU or SDU. And in SDU, later the patient is managed in terms of temperature control, ventilations, managing cardiac hemodynamic status, and investigations like echocardiography and further drugs. So if we will talk in details about those things, first, control of airway in post resuscitation phase in comatose patient, most of the time the patient will require a intubation and mechanical ventilation. If the duration of arrest is very small and the patient is awake, those things may be avoided and you can provide only oxygen. Intubation should be always by experienced operator, and after intubation, the proper placement of the enterotracheal tube should be confirmed by a waveform capnography. And if you are not able to intubate or you lack any experienced personnel, then you maintain ventilation either with a supraglottic device or a traditional technique, basic technique of bag and masking. Oxygenation target here is to provide 100% oxygen. However, you titrate the saturation between more than 94%, mostly between 94 to 98%, with a PO2 targeting around 100. You avoid any hypoxemia, that is PO2 less than 60 millimeter of mercury, and any hyperoxemia, which is more than 300 mm of Hg, should be avoided. There has been studies, and this is a meta-analysis which shows that hyperoxemia, that is PO2 more than 300 millimeter mercury, are detrimental or have a bad prognosis. Ventilation, again, you always have a arterial blood gas analysis, and you try to adjust ventilation to target a normal PCO2 between 35 to 45 millimeter mercury. In patients who are treated with TTM, that is therapeutic temperature management, monitoring of PCO2 frequently required to optimize the carbon CO2 levels. Use of long protective ventilation strategy, which are standardly used in the ICU, should be used. This is a infographics showing the targets that are the with up of the ventilation and hemodynamic status. We'll discuss again. After that, you always find out what is the cause. That is whether it's a cardiac cause or not. If there is a ST, you do a ECG, and if there is a ST elevation on the ECG, then definitely there is a high chance of uh, recovery or preventive cause of recurrent cardiac arrest if you go for a coronary angiography with or without any PCI or any intervention. However, if there is no ST elevation, then also you cannot rule out these occlusions, and there are specific patient groups which will help or which will be helpful if you go for a coronary angiography. We'll again discuss. Again, cause of cardiac arrest should be identified and patient to be admitted into ICU. And in the ICU, you start the post cardiac arrest care by again targeting these things: ventilation, hemodynamics, cardiovascular system, neurological or prevent brain injury, and metabolic things. Coming to respiratory care, it is basically the continuation of the immediate treatment or immediate care that patient has received. No optimal mode of ventilation is recommended for this group of patients. You always try to maintain the POCO2 within the normal physiological range. That is, however, one caveat is that if the patient is receiving TTM, that is therapeutic temperature management, the actual PCO2 may be low than the measured value. So you always take into consideration of this value. Again, oxygenation targets are same, which has been previously used. Maintain oxygen saturation more than 94%. However, if the patient is receiving a therapeutic temperature management towards the lower range, that is around 30 degrees centigrade, 33 degrees centigrade, the PO2 reported by the lab value may be higher than the patient's actual PO2. So again, these things should be taken into account. Cardiovascular care, the return of spontaneous circulation is always you do a 12-lead ECG as soon as possible. You do a ST segment analysis, and emergency coronary angiography is done in out of hospital cardiac arrest with suspected cardiac etiology and ST elevation. Comatose out of hospital cardiac patient without ST elevation but critically or unstable electrically or hemodynamically, or any other post cardiac patient in which angiography is indicated. So if you are assessing the need for immediate coronary revascularization, as we discussed, the patients with non-cardiac etiology for cardiac arrest, it is not warranted. However, in patients who have a cardiac etiology, you look for the any ST segment elevation or in development of any new left bundle branch block, where a emergency coronography is warranted. In patients with potential cardiac etiology but without any ST segment MI, coronary angiography can safely delayed in many patients without this. However, it may have a role in selected patients. Like in these group of patients, early angiography can be done who have no ST segment elevation. That are the known pre-existing coronary artery disease, evidence of recurrent ischemia, electrical or hemodynamic instability, or witness reported chest pain prior to the arrest. And those patients who have unexplained cardiac arrest, left ventricular dysfunction, recurrent symptoms after recovery for cardiac arrest, inducible ischemia on stress test, planned placement of an defibrillator, in this scenario, the angiography can be delayed. The recent literature, however, does not support the early versus late angiography in non-ST segment elevated MIs. This is the meta-analysis where they found that both in early and late angiography in this group of patients, the outcome is same. Vasopressors, vasoactive drugs.
This is for ST elevation or without ST?
Non-ST elevation.
Non-ST.
Yeah. So the vasoactive drugs may be administered after return of spontaneous circulation to support cardiac output. Any drug is not preferred. Vasoactive drugs must be titrated at the bedside to secure the intent effect with limited side effects. Coming to the hemodynamics, again, all the patients in the ICU should have a arterial line for continuous monitoring of blood pressure. Cardiac output monitoring, however, can be only or used in unstable patients. A early echo to find out any regional wall motion abnormality or any specific cardiac etiology must be done. The goal is to avoid an immediately correct in hypotension, that is the mean arterial pressure which is less than 65 millimeter of mercury. The target is to achieve a mean arterial pressure more than 65 millimeter of mercury with adequate urine output and decreased lactate clearance. Also, during those periods, you avoid steroids, avoid any hypokalemia, which may precipitate arrhythmias. Persisting cardiological shock is there. You can consider mechanical circulatory supports like intra-aortic balloon pump or VA ECMOs. Now coming to the neurological part. So here first we'll discuss the targeted temperature management, which is one of the major part in discussion in the post-cardiac arrest syndrome. So there are many questions: why, where, when to start, how to start. So we'll deal all of them one by one. First is why targeted temperature management should be done. With hypothermia, in animal studies, it has been found that it is neuroprotective. Each 1 degree temperature decrease the cerebral metabolic oxygen requirement by 6%. And that lead to less excitatory amino acid and free radical production, which may prevent further injury. With that, both in hospital and out of hospital cardiac arrest, after return of spontaneous circulation, those patients who are comatose, that is, they lack any meaningful response to verbal command, should receive a therapeutic temperature management. This is the normal or followed dictum till now. we'll discuss how the role of therapeutic temperature management evolved with time. So the coming to phases, basically there are three phases of therapeutic temperature management. One is induction, which is followed by maintenance and followed by a rewarming phase. For initiation of the technique, there are different technique. Mostly surface methods like water and air circulating blankets are used. Water circulating gel coated pads are also available. Mechanical intravascular catheters are available, which are helpful in cooling. And rapid infusion of cold saline or ice packs have been used traditionally. However, in this study, they don't found any evidence to recommend one cooling modality over the another. These are the different hypothermia devices. Like here, you can see. Uh, okay, the marker is not there. So these are
Marker
the
is there. The marker should be there. Just see here carefully. Marker is always, it's see pen.
yeah, yeah. So you can see these are the surface cooling methods like pre-cooled surface pads, water circulating pads, or any catheter-based endovascular devices which help in cooling. And newer devices by transnasal cooling machines are also available in the market. So setting the target temperature is like there are two approaches. Actually, it has been found that after the return of spontaneous circulation, the median temperature is around 35.3 degrees centigrade. With that, approaches has been classically used. One is known as therapeutic hypothermia, where the target is set between 33 to 36 degrees centigrade. Another is known as targeted normothermia, where the target is set between the 36.5 to 37.5 degrees centigrade. Both approaches should be coupled with proactive avoidance of fever for additional of at least 48 to 78 hours after discontinuation of this therapeutic temperature management. Which temperature to target may be depend upon the patient profile. Like a targeted normothermia may be preferred in case of mild brain injury, higher bleeding risk, trauma or recent surgery, septic shock, and patients with severe underlying comorbid medical condition, because there is a high risk of bleeding, arrhythmias, and electrolyte disturbance in these patients. So a targeted or normothermia will be preferred. However, in patients with stroke, severe vein injury, subarachnoid hemorrhage, hepatic encephalopathy, a therapeutic hypothermia may be of beneficial, as these patients have a greater degree of hypothermia may help in reducing cerebral edema and seizure activities. Timing, it should be initiated as early as possible. There has been a report of delayed initiation which lead to worst prognosis or worst outcome. However, there is no proven advantage of starting this therapeutic temperature management while the resuscitation is going on. Similarly, previously they have started this in the pre-hospital setting, but the current evidence does not support routine pre-hospital cooling of the patients with rapid IV cold IV fluids for therapeutic temperature management. Most of the time, these patients land up with fluid overload and pulmonary edema, which again further contribute to the morbidity and mortality. Whether different methods in the pre-hospital setting will help or not, that is not known till now. Delayed therapeutic starting of the therapeutic temperature management may be uh, advocated in certain scenarios, like patients who have evidence of ST segment elevation myocardial infarction on electrogram. In these patients, it is generally initiated once the revasculation has occurred. Similarly, in patients who have documented intracranial hemorrhage, this should not be delayed for neurologic and neurosurgical evaluation. The optimal duration is not known till now. However, it must be maintained for at least 24 hours after achieving the target temperature. Many studies have till now used from 8 hours to 28 hours for the duration of therapeutic temperature management. Maintenance of temperature. So you should always monitor the temperature during this TTM. Core temperature should be monitored. Axillary and tympanic membrane measurements should not be used because they do not represent the core temperature. Esophageal, bladder, and rectal probes can be used, and which out of these, the esophagus probes are preferred as they much more closely represent the core temperature. Bladder temperature may be fluctuate if there is a fluctuation with urine output. Similarly, the rectal probe temperatures normally lag behind the change in core temperatures. So esophageal temperatures are better.
Which method you recommend, sir? Core temperature?
Esophageal probe,
Esophageal probe. What about nasopharyngeal?
lower end of the esophageal.
Nasal probe?
Anything that will go to the lower one
Okay.
third of the esophagus.
Okay.
Maintenance sedation should be provided during this temperature therapeutic temperature management. Most of the time, normally what we use as propofol plus fentanyl infusion. Alternatively, people have used midazolam, but which should not be used because it will take a long time for the recovery and it will delay the prognostication pattern. Sedation should be titrated as per the sedation scales. Monitoring, there is no recommended how frequently you should monitor these things, but normally people have monitors these complete blood count chemistries like potassium, magnesium, calcium, INR, APTT, lactate, and cardiac enzymes 4 to 6 hourly during this period. Now coming to rewarming, which prevent fever actively in comatose patient after this one. Rebound hypothermia may have a worst neurological outcome. Optimal rate of new warming is not known, but mostly we target around 0.25 to zero point 0.5 degrees centigrade per hour. The best way of rewarming is that you stop all the intervention that you are doing to maintain the cool temperature. That will normally take care of this one, and that will be slow rewarming. Active rewarming is not recommended. Adverse of effect during the therapeutic temperature managements are the mostly shivering and coagulopathy. For shivering, it is mostly you titrate the sedation. We mostly use fentanyl and propofol. In refractory cases, dexmedetomidine, neuromuscular blockade, and meperidine can be used. The problem with dexmed is that there will be bradycardia and hypotension. With neuromuscular blockade agent, if you are using as a last resort, but that will hamper in observing any seizure activities, and meperidine itself has a procoagulant effect. So these things should be considered while using these drugs. Coagulopathy occurs, but however, clinically significant bleeding mostly occurs in 20% of the patients. If you have bleeding and it is not correctable, the TTM should be stopped. Arrhythmias like bradycardia and QT prolongations are mostly seen. QT prolongation is much more seen if your other drugs are used which are known to cause the QT prolongation. There has been report of QT prolongation where it has been used with antibiotics like fluoroquinolones.
Even Dexam can increase the QTs.
Yes, yes.
Okay.
So this hypothermia normally causes a cold diuresis that will lead to loss of electrolytes, mostly causing electrolyte imbalance and hypovolemia. There is a hyperglycemia, which is mainly because of insulin resistance, and that is managed with standard way of managing glycemias. Increased risk of infection is literature mentioned in the literature. However, there has been trials which does not found any increased risk of infection with patient with TTM.
Just add to that, Dr. Besure, if you may.
Yes.
There is neutrophilic dysfunction, but there is no increased risk of infection. TLC is also low. Actually, because of hypothermia. Hypothermia causes a neutropenia, but the CPR and the process of resuscitation actually increases the TLC. So that is known, and also there is no recommendation to give prophylactic antibiotics.
Yes, definitely.
You just said, people think there will be aspiration pneumonia. So if you get aspiration pneumonia, then only give the antibiotics. There is recommendation to give
found any evidence of infection, then only use antibiotics.
Yes,
Prophylactic
like you
antibiotics
said.
are not indicated.
Well,
This has been one protocol given in literature how to manage the shivering, where they started before the starting of therapeutic temperature management by using paracetamol and targeting a magnesium of more than 0.8 millimoles per liter. And during shivering, again, as you discussed, you use propofol, fentanyl, ribofentanil, dexmedetomidine or clonidine infusion, and again target a magnesium of more than 1.2. And later, if everything fails, you can consider muscle relaxation as a last resort. efficacy and evidence regarding therapeutic temperature management. It all began with animal studies, followed by these two studies way back in 2002, the HACA and the Bernard trial. The Bernard is a small trial, however, the HACA is a larger trial, around 581 patients are there. And it shows that there is a absolute 18% reduction in mortality after 6 months if you are using a therapeutic hypothermia. So these reports are very encouraging, and everybody started to use the therapeutic hypothermia and becomes popular. However, the limitation in both the studies are not blinded. So there is a very high chance that those patients who are receiving the intervention, in that group they have extra care. Also, they don't take care of the fever. In the control group, in both the studies, 8% to 9% of the population have fever. Followed by, it comes to 2013, when the therapeutic TTM trial comes in New Journal NEGM, where what they did, they compare the 33 degrees centigrade versus 36 degrees centigrade after cardiac arrest for as a therapeutic target. However, they don't find any hypothermia. Hypothermia at a target temperature of 30 degree did not confer any benefit compared to the target temperature of 36 degree centigrade. Despite this, the with that the use of tritium does not decrease. It continued, and later that is there is a Hyperion trial, where it's a small trial compared to the TTM trial, in which around uh, 500 patients are there, and they compared between 33 degrees centigrades and the normothermia, and they found a moderately significant result, that is the neural outcome is 10%, 2% versus the 5.7%. Again, this is a positive trial which encourages everybody to use the TTM. However, the last year we have the TTM2 trial, where they compared. It's a multicentric trial, and they have included around 36 centers all over the world. Around 1850 persons are included, and they compare hypothermia at 33 degrees centigrade with normothermia, that is more than 37.5 degrees temperature. And here they don't found any benefit of using a hypothermia. So this trial is a robust trial, and it is very well designed. So any chance of criticism with this was very minimal. So with different times, the therapeutic temperature intervention or targeted temperature management has changed, and now just situation where last year the European Resuscitation Council and EICSM changed their guidelines of 2021 in 2022 regarding the temperature management in post cardiac arrest adult. What they say is that in patients who remain comatose after cardiac arrest, we recommend continuous monitoring of core body temperature. There is insufficient evidence to recommend for or against temperature control between 32 to 36 degrees centigrade or early cooling after cardiac arrest. They recommend not actively rewarming comatose patients with mild hypothermia. Also, they recommend using pre-hospital, not using pre-hospital coolings as previously. And these are the recommendations in which particularly they don't say the maintaining a temperature between 32 to 36 degrees, they don't have any strong evidence. So we recommend not actively rewarming the comatose patients with mild hypothermia and ROCS. However, with this evidence, should you discard the use? Many people have not stopped using the TTM till now, and that is the right approach. Although there is little evidence, there may be a specific group of patients which may be helpful with the temperature management. We should not throw the baby along with the water. And recently, in 2020 and 22, there are few studies in which they found out in patients who have a moderate degree of severity of post cardiac arrest syndrome, they may have a benefit from this therapeutic hypothermia. And these things should be explored before clearly discarding the therapeutic temperature management. But one thing is clear: we should not aim for hypothermia, and we should avoid hyperthermia at all cost. Other neurological considerations like seizure management, it is around 33% of patients have seizures. Evidence does not support any prophylactic administration of anticoagulants. anticonvulsants. However, a prompt ECG for diagnosis of seizure is recommended. You can use a continuous or intermediate EEG. Previously, there is no specific recommendation, but last time this they have recommended levetiracetam and sodium valproate as the first line anti-epileptic drugs for these seizures.
Dr. Day, just like to ask you, what are you using EEG monitoring in your ICU?
No, we don't have a EEG monitor in our department. We
Ah.
have a EEG. We are in the process of buying EEG, but we have a EEG in the neurology department. But it is very difficult logistically
So
to.
it's SOS as per the.
Yes, we are not. It is recommended, but we are not using.
Yeah, so that is that is what I wanted to highlight. Actually, the guidelines. See, seizure
Yes,
activity is very common, and that is if the EEG is not there, then prophylactic anti-epileptics do not know whether to give or not, because these are Western guidelines. They monitor
yes,
EEG, so it's
yes.
debatable.
They actually without EEG it is very because you are using sedation also. So there may be chances of non-convulsive
Yes,
seizure for
yes. So
my.
the role of profile is
Yeah,
very high, the frequency. So we don't have EEG monitoring in most of the ICUs. You don't
yes,
have, so what the smaller ICUs will do. So there is a point for the using a prophylactic antiepileptic, especially the first 48 hours. Just
yes.
a point.
Some people have used some clinical criteria to find out in a sedated person whether any epileptic activity is going or not. But again, those are very sensitivity is very less. So many people also we land up using prophylactic anti-epileptics.
I think it makes sense to use at least for 48 hours, 72 hours
Yes,
till you reach a situation of prognostication.
yes. Till the prognostication at least for 72 hours you can use definitely. If you don't have any EEG monitoring, that is much more convenient for our ICU setup rather than these Western
Yes, yes.
guidelines.
I think it makes sense to use. The frequency of seizure is very high.
Yes.
Yes, sir.
Metabolic glucose control is again any specific target is not achieved for this group of patients. The normal target of 140 to 180 milligram per deciliter should be followed. You avoid any hyperglycemia. General ICU cares like using short-acting sedatives, evidence of neuromuscular blocking agents, stress ulcer prophylaxis, venous thrombosis prophylaxis, starting internal feeding early are all should be followed. However, specifically if you are the patient is on a therapeutic temperature management and not as a therapeutic in the higher range, mostly in the 36-degree or uh, normothermia range, then you can quietly start the normal feeding. Previously, when you are using a lower temperature, it is warranted to not to use a high dose of feeding. But nowadays, most of the people go with feedings. Routine prophylactic antibiotics are not recommended. Also, we don't use those things in this patients. Now, coming to the important point is the prognostication of outcome. You have taken care of the first 3 days or first to 3 days or initial phases where most of the hemodynamic and neurological activity is there. Now, to time is to tell the family or the relatives how the patient is going to behave further. So normally the prognostication, it is advisable to use a combination of these parameters like the clinical examinations, neurophysiological readings, biomarkers, and imaging. However, any one of them has not to be found to be a good prognosticated factor alone. A combinations, again, they are not 100% proof, but they have a better uh, chance of giving a proper prognosis. Timing of outcome for prediction, if you are using a therapeutic temperature management, it should be at least 72 hours after return of normothermia. If it is no therapeutic temperature management, it should be 72 hours after cardiac arrest. However, this time limit is not fixed. You can go beyond that as till if you found that there is a the sedative drugs or the effect of the drugs are not over. Previously, these clinical parameters has been found to be have unfavorable prognosis, like duration of anoxia more than 10 minutes, duration of CPR more than 30 minutes, pupillary light reaction absent on 3 day, motor response absent on day 3, brainstem reflexes or glucose concentration at admission more than 300 milligram per deciliter. But these has not found to be a quantitative way to prognosticate this patient. Currently, the clinical examinations they say in patients who remain comatose after 72 hours or later, these things may help in may have some prognosticate role or have some poor prognostic outcomes. If they have bilateral absence of pupillary light reflex, bilateral absence corneal reflex, they have advocated using quantitative pupillometry to find out these things. And if any presence of myoclonus within 96 hours, or especially if you have a status myoclonus within 72 hours, the status myoclonus is like continuous myoclonus for more than 30 minutes. Neurophysiological outcome is for prediction is like EEG should be monitored in all the patients who are comatose in arrest. Are poor prognostic factors with EEG are that highly malignant type of patterns like suppressed backgrounds with periodic discharges or burst depression, presence of equivocal seizures on EEG during the first 72 hours, absence of background reactivity in EEG, and bilateral absence of somatosensory evoke and cortical N20 potential. It has been said that it may be difficult to interpret the EEG with the sedation and other things. So you may take help from the neurologist or specific person who are much more experienced in interpreting these EEGs in the ICUs. Biomarkers, mostly neuron specific amylase and S100B has been used, but they should not be used for individually for prognostication. Currently, there has been increasing role of neural specific amylase, increasing value of neuro NSC between 24 and 48 hours or 72 hours in combination with high value at 48 and 70 hours may have poor prognosis factor. Imaging, again, it should not be used as a alone factor. It should be used in combination with others. And they advocate again to interpret these or do this imaging, especially in those scenarios or those hospitals who are doing it routinely. There are many features that has been advocated of having poor outcomes, but none of them are consistent with these things. Multimodal prognostication that is recommended by the European Society. So if the patient have a ROCS, the targeted temperature management or rearming has been done. And if the patient is unconscious with a motor score of less than equal to 3 at 72 hours without any co-founder, and out of these six, any two of them are present, the patient has a poor outcome. Like non-pupillary or no pupillary and corneal reflex, bilateral absent N20 evoke potentials, highly malignant EEG pattern at more than 24 hours, NSE more than 60 microgram per deciliters, status myoclonus or diffuse or extensive anoxic injury on brain CT or MRI. However, these things, most of the things are normally not available in normal ICUs. So these can only be used in a high profile center where all the modalities are available. Withdrawal of life support uh, after like therapy is that you always discuss with the family, and they advocate this discussion of withdrawal of life support and prognostication should be different, not in the same setting, and you should give adequate time for the family or the next to kin to have a combination or have some opinions before taking any decisions. The same things apply for the ICU team also. Rehabilitation is the next thing after these things. After long-term outcome after cardiac arrest, they say you always, if the patient survives and goes through the normal course, you perform a functional assessment or a physical and non-physical parameters. Uh, then patient is referred to a rehabilitation center if necessary. The current guidelines mandate at least for visit after 3 months for a follow-up. Sorry, basically to find out screening for cognitive problems or any emotional problems or any supportive or any type of support that can be provided to the victim or the family. Organ donation, all patients who have resuscitated from the cardiac arrest but who subsequently progress to death or brain death may be evaluated for organ donation. And the algorithm is that any unresponsive patients after ROCS or suspected neurological cause of arrest. If there, you should a brain CT. If no, then therapeutic temperature management and rewarming should be done. All brainstem, if the all brainstem reflexes are absent, then again you go for brain CT. However, all these things are for a Western scenario. In Indian, we have a different set of guidelines where that should be followed if we are planning for the organ donation. However, one important thing is that the treating physician or the ICU physician should not be directly involved in the decision making as per the law of in our country. And those specialized team or the orbo team who is responsible for that, they should assess it for organ donation. The current concept as per the European guidelines is that there should be cardiac arrest centers, mostly in higher centers, and adult patients with non-traumatic out-of-hospital cardiac arrest should be considered to transport to these centers for proper management. However, these are newer concept and it will take time to be implemented. And in our scenario, it will be much more difficult currently. To summarize, the post-cardiac arrest syndrome should be initially stabilized, followed by managed in the ICU or SDU. Emergency cardiac intervention should be evaluated at the initial stages. Whether to do a target temperature management or not is controversial, although the current evidence is not favoring these temperature managements. Most of the ICUs still practice these things. However, the important thing is that you should always at every point avoid any fever. Prognostication should be used after 72 hours, and it should use multiple factors like clinical, neuroimaging, neuromodulation, and any marker if available, and consider organ donation if possible. Any questions?
So thank you, Dr. Bikash, sir. Very nice slides. Just stop the share screen, sir.
Yes.
So wonderful lecture, nice slides, beautiful slides, and very nice content, updated content. Any questions from anybody? Please put the questions. So I will just like to add a few things from my side to what you have said, very nicely covered. First of all, in the ICUs, so let's take the question. Any difference between management of OHCA and out of hospital and in hospital cardiac arrest?
Yes. Most of the data regarding the temperature management are previously from the out of hospital cardiac arrest. However, those data can be extrapolated into in hospital cardiac arrest, and the same principle goes on. In also now, however, now also we have data in mainly in hospital arrest, and it's a continuing process. So there is no difference in current literature regarding the management of out of hospital uh, in hospital management regarding this temperature management.
Absolutely. So any other questions, please type while I'll just add something to that. So one thing is difference will be that you'll have to look at the etiology. In the etiology in the hospital, in the ICU, the cardiac arrest occurs, it is the 6H and the 6T you have to look at. But when the patient comes from outside, it's a little different. In the elderly patient, probably it will be cardiac arrest, MI. MI would be the commonest cause. And in the younger patients, there would be arrhythmias, all kinds of arrhythmias and other causes like CNS causes, intracranial bleed, etc. would have to be considered. So the etiology is a little different in out of hospital cardiac arrest and in-house cardiac arrest. That is one thing. The overall management remains the same.
Then, the main point is to find out whether there is a cardiac etiology or not in both scenarios, and yes, it is easily find out in in-hospital admitted patient rather than the out-of-hospital patient.
Absolutely. Then the other thing is like Dr. Bikash sir said, patients who are M6 do not need to undergo any therapeutic hypothermia. They have to be managed just with critical care. Then the maximum time duration beyond which you should not do therapeutic hypothermia is 12 hours. It should be done within 12 hours. That's the upper limit. It should not be done beyond 12 hours. And the only contraindication is non-compressible bleed. Sepsis is not a contraindication. Only contraindication is non-compressible significant bleed. Now, coming to a few other things, when the patient undergoes resuscitation or has had an MI or something, often the cardiac function is depressed. If you do the echo, the cardiac function is depressed. But generally, after ROC is achieved and you continue your critical care, after 48 to 72 hours, the cardiac function returns to normal, more or less. And within the next few days, returns to complete normalcy. If the cardiac function is not returning to near normalcy in 72 hours, either the patient has had a MI or there was a pre-existing cardiomyopathy. That is very important to know. That the cardiac function returns to normal if it was normal before the event and there was no MI. Now, the other thing is about SIRS. So, sir mentioned about reperfusion injury. So, what happens is in this reperfusion injury, Dept molecules are released, extensive Dept molecules, because the reperfusion everywhere. So, these Dept molecules lead to SIRS, and there can be persistent organ injury in different organs because of SIRS. SIRS post myocardial resuscitation is a phase of SIRS in the next 24, 48, 72 hours, and you can have persisting hypotension. The cardiac function may return to normal, but there can be persisting hypotension, and this hypotension should be identified as SIRS, as not as something else like sepsis has set in. So sepsis can also set in, but you have to discriminate. This is again very important. Now, the other thing is prognostication. Sir has said about the controversy. Sir has very clearly said the current guidelines. He has shown you the data. 36 degrees around. It should be around 37, 36 degrees. Hypothermia, whether it should be attained or not, is not clear. They have recommended to keep it at normothermia. Fever should not occur. Fever is detrimental because it increases the oxygen consumption, increases the blood flow, increases the edema, the toxic molecules in the brain. Fever is detrimental. So those were a few things. The other thing is the heart rate. If you are practicing deeper hypothermia like 33 degrees, your heart rate can dip down to less than 40 degrees. 40 per minute. So in these patients, what you do? Don't give atropine. You have to increase the temperature. You have to increase the temperature a little so the heart rate comes up beyond 40. So just a few things, and please know the physiological changes in hypothermia, because like sir said, still most of the centers are practicing hypothermia. Though the international guidelines published 6 months ago by European Society after the meta-analysis of the TTM2 trial and the earlier trial, 2-3 major trials, that there is no convincing evidence, and they have recommended normothermia. So we had the lecture earlier on hypothermia by Dr. Vatsal Kothari from Mumbai. So you can look up the lecture on hypothermia, physiological changes, etc. That should be known to everybody, because what is happening, you should know. For example, PT-APTT goes up. The TLC decreases in hypothermia. Lactate goes up. Amylase and lipase can increase. LFT can increase a little. So all these things should be known, because they can be confounding factors if something else sets in. So that is a few things I wanted to add from my side. Your Bikash sir, your comment.
One more thing that I missed is that it is very difficult if you are practicing a therapeutic temperature management. It is very difficult to maintain a constant temperature, and it has been found that a fluctuation of temperature is much more worst outcome rather than a steady temperature. So it is better to go maintain a 36 degree temperature, which is much more physical possible, rather than targeting lower temperature and fluctuating the temperature. That is another thing.
Absolutely.
And that, yeah.
There's another question. After 72 hours, radiologically, do we need an MRI or a CT is enough for neuroprognostication? So
No, it is not.
Yeah, carry on, sir. You answer.
Yeah, sir. So the question is that is it MRI or CT is enough? No, it is not enough. Anything out of the prognostic factor, either clinical, either imaging or radiological, or the biomarkers, or the neuro functioning or modulations, now none of the factors can individually predict the prognostication or predict given for prognostication. A combination of approach will be used, and only MRI, as I told you, there are many findings, but no single finding is consistent with the prognosis of bad prognosis or poor prognosis. So it is not, only MRI is not sufficient at 72 hours for prognostication.
Yeah, so just like to add to that, and there is no objective criteria on MRI for diagnosing how bad the patient is or how bad the prognosis is. Like sir said, it's a combination, and it's a subjective criteria. Only the experienced neurologist will say how bad the situation is on the MRI, and it is one of the criteria. But definitely MRI would be needed, because CT is not really going to show you too much, unless of course there are gross changes like massive intercellular bleed and those things. So that is about the imaging at 72 hours.
For prognostication, if you are using, use MRI.
Any other questions? Anything else you want to add, sir, from your side?
Uh,
Anything else you
no,
want to talk about your experience? Anything interesting case?
regarding normally therapeutic, we don't go for a lower temperature as per yes, but normally we what you use for nowadays we have stopped those things. Previously we used to use mostly the surface methods. I don't have any experience of using any intravascular devices or modern techniques, but if you want to decrease the temperature, we are mostly using the surface methods, and otherwise all standard care are similar most of the time.
Yes, yes. And like you said earlier, it should be immediately as soon as possible. You should achieve the target temperature if you are going for hypothermia, because delay has been associated with uh, delay, worsening of outcome or negligible effect of hypothermia. But then again, the question of whether there should be a hypothermia or not is not settled. It is a gray zone right now. So,
Yes.
this is the current evidence and current recommendations. And if you want to read, sir had shown the evidence. There is European Resuscitation Council Guidelines 2021 published in intensive care medicine. I had shared this also in my Telegram group. So you can go through this European Resuscitation Council. They're the latest 2021 guidelines. And after that, there was this recommendation on TTM. Wow, should be maintained. That's about it. So I think, sir, there are no more questions. Thank you very much for your lovely slides, your time and effort, and beautiful talk. Thank you very much. See you again, sir. Bye-bye.
Thank you, Dr. Bansal. Thank you, thank you.